Hello. Thank you for joining us today. We are really glad you are here. Please sit back and open your hearts. Here's Jim, your host of Time Out with Jim. So, let's get started.
Today we are going to talk about OCD, which stands for Obsessive Compulsive Disorder. It is a mental disorder in which a person has certain thoughts repeatedly, called obsession, or feels the need to perform certain routines repeatedly, called compulsion, to an extent which generates distress or impairs general functioning. The person is unable to control either the thoughts or activities for more than a short period of time. Common compulsions include hand washing, counting of things. With me, that's what I do. I count stuff like tiles, steps that I take, and checking to see if a door is locked. These activities occur to such a degree that the person's daily life is negatively affected, often taking up more than an hour a day. Most adults realize that the behaviors do not make sense. The condition is associated with tic anxiety disorder and an increased risk of suicide. The cause is unknown. There appear to be some genetic components with both identical trends more often affected than both non-identical. Treatment involves psychotherapy, such as cognitive behavior therapy, and sometimes antidepressants, such as selective serotonin reuptake inhibitors or clomipramine, CBT for short, or OCD, involves increasing exposure to what causes the problem while not allowing the repetitive behavior to occur. Contrary to this, metacognitive therapy encourages the ritual behaviors as to alter the relationship to one's thought about them, while CBT appears to work well as SSRIs. It has greater side effects and thus is typically reserved as a second-line treatment. Atypical antipsychotics may be useful when used in addition to an SSRI in treatment-resistant cases, but are also associated with an increased risk of side effects. With treatment, this condition often lasts decades. OCD affects about 2.3% of people at some point in their lives, while rates during any given year are about 1.2%. It is unusual for symptoms to begin after the age of 35, and half of people develop problems before 20. Males and females are affected about equally, and it occurs worldwide. The phrase obsessive compulsive is sometimes used in an informal manner unrelated to OCD to describe someone as being excessively meticulous, perfectionistic, absorbed, or otherwise fixated. OCD can present with the wide variety of certain groups of symptoms usually occur together. These groups are sometimes viewed as dimensions or clusters. They may reflect an underlying process. The standard assessment tool for OCD. These symptoms fit into 3 to 5 groupings. The forbidden thoughts factor, correlated highly with intrusive and distressing thoughts of violence, religious, or sexual nature. The cleaning factor, correlated highly with obsessions about contaminations and compulsions related to cleaning. Now, I do that sometimes. I get in this mood that I just want to clean anything and everything in the house. I call it my cleaning mood, and no one can tell me stop until I think everything looks good. The hoarding factor only involved hoarding-related obsession and compulsion compulsion and was identified as being distinct from other symptom groupings. Obsessions are thoughts that recur and persist despite efforts to ignore or confront them. People with OCD frequently perform tasks or compulsions to seek relief from obsession-related anxiety within and among individuals. The initial obsession or intrusive thought vary in their clarity and vividness. A relatively vague obsession could involve a general sense of disarray or tension, accompanied by a belief that life cannot proceed as normal, while the imbalanced image of someone close to them dying. A relatively vague obsession could involve a general disarray or tension, accompanied by a belief that life cannot proceed as normal, while the imbalance remains. A more intense obsession could be a preoccupation with the thought or image of someone close to them dying, or intrusions related to relationship rightness. Other obsessions concern the possibility that someone or something other than oneself, such as God, the devil, or disease, will harm either the person with OCD or the people or things that the person cares about. Other individuals with OCD may experience the sensation of invisible protrusions emanating from the body, or have the feeling that inanimate objects are installed. People with OCD may attach extraordinary significance to the thoughts. For example, obsessive fears about sexual orientation can appear to the person with OCD, and even to those around them, as a crisis of sexual identity. The doubt that accompanies OCD leads to uncertainty regarding whether one might act on the troubling thought, resulting in self-criticism or self-loathing. Most people with OCD understand that their notions do not correspond with reality. However, they feel that they must act as though the notions are correct. For example, an individual who engages in compulsive hoarding might be inclined in organic matter as if it had the sentience or rights of living organisms, while accepting that such behavior is irrational on a more intellectual level. There is a debate as to whether or not hoarding should be considered with other OCD symptoms. OCD sometimes manifests without overt compulsion, referred to as primarily obsessive OCD without overt compulsion. By one estimate, characterized as many as 50 to 60% of OCD case compulsion. Skin picking disorder. Some people with OCD perform compulsive rituals because they inexplicably feel they have to, while others act impulsively so as to mitigate the anxiety that stems from particular obsessive thought. A person might feel that these actions somehow either will prevent a dreaded event from occurring or will push the event from the thought. In any case, the individual's reasoning is so idiosyncratic or distorted that it results in significant distress for the individual. Biting and other body-focused repetitive behavior disorders are all on the obsessive-compulsive spectrum. Some individuals with OCD are aware that their behaviors are not rational, but feel compelled to follow through with them to fend off feelings of panic and dread. Some common compulsions include hand washing, cleaning, checking things, repeating actions, turning on and off switches, praying, ordering items in a certain way, searching the internet for answers, and requesting reassurance. Yeah, Well, I gotta say, the requesting reassurance, I do that a lot. Compulsions are different from tics, such as touching, tapping, rubbing, or blinking, and stereotype movements such as head banging, body rocking, and self-biting, which usually are not as complex and are not precipitated by obsession. It can sometimes be difficult to tell the difference between compulsions and complex tics. About 10% to 40% of individuals with OCD also have a lifetime tic disorder. People rely on compulsions as an escape from their obsessive thoughts. However, they are aware that the relief is only temporary, that the intrusive thoughts will soon return. Some people use compulsions to avoid situations that may trigger the obsession. Although some people do certain things over and over again, they do not necessarily perform these actions compulsively. For example, bedtime routine, learning a new skill, religious practices are not compulsion. Whether or not behaviors are compulsion or mere habit depends on the context in which the behaviors are performed. For example, arranging and ordering books for 8 hours a day would be expected of one who works in a library, but would seem abnormal in other situations. In other words, habit tends to bring efficiency to one's life, while compulsions tend to disrupt it. In addition to the anxiety and fear that typically accompanies OCD, sufferers may spend hours performing such compulsions every day. In such situations, it can be hard for the person to fulfill their work, family, or social roles. In some cases, people who obsessively wash their hands with antibacterial soap and hot water can make their skin red and raw with dermatitis. People with OCD can use rationalizations to explain the behavior. However, these rationalizations do not apply to the overall behavior, but to each instance individually. For example, a person compulsively checking the front door may argue that the time taken and the stress caused by one more check of the front door is much less than the time and stress associated with being robbed, and thus checking is the better option. In practice, after that check, the person is still not sure and deems it is still better to perform one more check. And this reasoning can continue for as long as necessary. In cognitive behavior therapy, OCD patients are asked to overcome intrusive thoughts by not doing any compulsion. They are taught that rituals keep OCD strong. By not performing these causes the OCD to become weaker. Overvalued ideas. Some people with OCD exhibit what is known as overvalued ideas. In such cases, the person with OCD will truly be uncertain whether the fears that cause them to perform their compulsions are irrational or not. After some discussion, it is possible to convince the individual that their fears may be unfounded. It may be more difficult to do ERP therapy on such people because they may be unwilling to cooperate, at least initially. There are severe cases in which the person has an unshakable belief in the context of OCD that is difficult to differentiate from psychotic disorders. Though it was once believed to be associated with above average intelligence, this does not appear to be necessarily be the case. A 2013 review reported that people with OCD may sometimes have mild but wide-ranging cognitive deficits, significantly regarding spatial memory to a lesser extent with verbal memory, fluency, executive function, and processing speed. While auditory attention was not significantly affected, people with OCD show an impairment in formulating an organizational strategy for coding information, set shifting, and motor and cognitive inhibition. Special subtypes of symptom dimensions in OCD have been associated with specific cognitive deficiencies. Cognitive deficit, for example, the results of one meta-analysis comparing washing and checking symptoms reported that the washers outperformed checkers on 8 out of 10 cognitive tests. The symptoms dimension of contamination and cleaning may be associated with higher scores on tests of inhibition and verbal memory. Approximately 1 to 2% of children are affected by OCD. OCD symptoms tend to develop more frequently in children that are 10 to 14 years age, with males displaying symptoms at an earlier age and a more severe level than females. In children, symptoms can be grouped into at least 4 types. Individuals with OCD have been found to be affected by delayed sleep phase syndrome at a substantially higher rate than the general public. However, severe OCD symptoms are consistently associated with greater sleep disturbance, reduced total sleep time, and sleep deficiency have been observed. People with OCD, which delayed sleep onset and offset, and an increased prevalence of delayed sleep phase disorder. Behaviorally, there is some research demonstrating a link between drug addiction and the disorder as well. For example, there is a higher risk of drug addiction among those with high anxiety, possibly as a way coping with the heightened levels of anxiety, but drug addiction among people with OCD may serve as a type of compulsive behavior and not just as a coping mechanism. Depression is also extremely prevalent among people with OCD. One explanation for the high depression rate among OCD populations explains that people with OCD or any other anxiety disorder may feel depressed because of an out of control type of feeling. OCD frequently co-occurs with both bipolar disorder and major depression. Between 60 to 80% of those with OCD experience a major depressive episode in their lifetime. Comorbidity rates have been reported at between 19 to 90% due to methodological differences. Between 9 and 35% of those with bipolar disorder also have OCD, compared to the 1 to 2% in the general population. Around 50% of those with OCD experience cyclothymic traits or hypomanic episodes. OCD is only associated with anxiety. It is also associated with anxiety disorders. The cause is unknown. Both environmental and genetic factors are believed to play a role. Risk factors include a history of child abuse or other stress-inducing events. Drug-induced OCD. Many different types of medication can create and induce pure OCD in patients that have never had symptoms. A new chapter about OCD in the DSM-5 is now specifically includes drug-induced OCD. Atypical antipsychotics such as olanzapine, Zyprexa have been proven to induce de novo OCD in patients. There appear to be some genetic components with identical trends more often affected than non-identical trends. Individuals with OCD are more likely to have first-degree family members exhibiting the same disorders than do matched controls. In cases where OCD develops during childhood, there is a much stronger familiar link in the disorder that causes in disorder than cases in which OCD develops develop later in adulthood. In general, genetic factors account for 45 to 65% of the variability in OCD symptoms in children. Diagnosed with the disorder, a study found evidence supporting the possibility of OCD being inherited. And that's going to be it for part one of OCD. Next time we will start off with cognitive models. Remember, materials contained on here are for informational purposes only. The content is not intended to be a substitute for professional advice, diagnosis, or treatment. Always seek the advice of your doctor or other qualified health provider with any question you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because it's something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Let's get started. Today we're going to be on part 2 of OCD, and we're going to start out with cognitive models. Generally, two categories of models for OCD have been postulated. The first involving deficits in executive function, and the second involving deficits in modulatory control. The first category of executive dysfunction is based on the observed structural and functional abnormalities in the DLPFC, striatum, and thalamus. The second category involving dysfunctional modulatory control primarily relies on observed functional and structural differences in the ACC, MPFC, and OS. One proposed model suggests that dysfunction in the OSC leads to improper evaluation of behaviors and decreased behavior control, while the observed alteration in amygdala activation leads to exaggerated fears. Another model proposes that effective dysregulation links excessive reliance in habit-based action selection with compulsion. This is supported by the observation that those with OCD demonstrate decreased activation of the ventral striatum when anticipating monetary reward, as well as increased functional connectivity between the VS and the OSC. Those with OCD demonstrate reduced performance in Pavlovian fear extinction tasks, hyper-responsiveness in the amygdala to fearful stimuli, and hyper-responsiveness to the amygdala when exposed to positively balanced stimuli. Stimulation of the nucleus accumbens has also been observed to effectively alleviate both perception and compulsion, supporting the role of effective dysregulation in generating both. A complex relationship between dopamine and OCD has been observed through antipsychotics, which act by antagonizing dopamine receptors may improve some cases of OCD. They frequently exacerbate others. Antipsychotics in the low doses used to treat OCD may actually increase the release of dopamine in the prefrontal cortex, through inhibiting autoreceptors. Further complicated things is the efficiency of amphetamines, decreased dopamine transporter activity observed in OCD, and low levels of D2 binding with the striatum. Furthermore, increased dopamine release in the nucleus accumbens after deep brain stimulation correlates with improvement in symptoms, pointing to reduced dopamine release in the striatum playing a role in generating symptoms. Formal diagnosis may be performed by a psychiatrist clinical social worker, or other licensed mental health professional. To be diagnosed with OCD, a person must have obsessions, compulsions, or both. Such obsessions are recurrent and persistent thoughts, impulses, or images that are experienced as intrusive and that cause marked anxiety or distress. These thoughts, impulses, or images are of a degree or type that lies outside the normal range of worries about conventional problems. A person may attempt to ignore or suppress such obsessions or to neutralize them with some other thought or action, and will tend to recognize the obsessions as irrational. Compulsions become clinically significant when a person feels driven to perform them in response to an obsession or according to rules that must be applied rigidly, and when the person consequently feels or causes significant distress. Therefore, for many people who do not suffer from OCD may perform actions often associated with OCD, as ordering items in a pantry by height. The distinction in clinically significant OCD lies in the fact that the person who suffers with OCD must perform these actions, otherwise they will experience significant psychological distress. These behaviors or mental acts are aimed at preventing or reducing distress or preventing some dreaded event or situation. However, these activities are not logical or practical connected to the issue, or they are excessive. In addition, at some point during the course of the disorder, the individual must realize that their obsessions or compulsions are unreasonable or excessive. The obsessions or compulsions must be time-consuming, taking up more than 1 hour per day, or cause impairment in social, occupational, or scholastic functioning. It is helpful to quantify the severity of symptoms and impairment before and during treatment for OCD. In addition to the person's estimate of the time spent each day harboring obsessive-compulsive thoughts or behaviors, concrete tools can be used to gauge the person's condition. This may be done with rating scales such as the Yale-Brown Obsessive-Compulsive Scale, with measurements like these. Psychiatric consultation can be more appropriately determined because it has been standardized. OCD is sometimes placed in a group of disorders called the obsessive-compulsive spectrum. People with OCD are often aware that their behavior is not rational or unhappy about their obsessions, but nevertheless they feel compelled by them. By contrast, people with OCPD are not aware of anything abnormal. They will readily explain why their actions are rational. It is usually impossible to convince them otherwise, and they tend to derive pleasure from their obsessions or compulsions. A form of psychotherapy called cognitive behavior therapy, CBT, and psychotropic medications are first-line treatments for OCD. Other forms of psychotherapy, such as psychodynamic and psychoanalysis, may help in managing some aspects of the disorder, but the American Psychiatric Association noted a lack of controlled studies showing their effectiveness in dealing with the core symptoms of OCD. One exposure and ritual prevention activity would be to check the lock only once and then leave. The specific technique used in cognitive behavior therapy is called exposure and response prevention, or ERP, which involves teaching the person to deliberately come into contact with the situations that trigger the obsessive thoughts and fears exposure without carrying out the usual compulsive acts associated with the obsession. Response prevention. Thus, gradually learning to tolerate the discomfort and anxiety associated with not performing the ritualistic behavior. At first, for example, someone might touch something only very mildly contaminated, such as a tissue that has been touched by another tissue, that has been touched by the end of a toothpick, that has been touched by a book that came from a contaminated location, such as a school. That is the exposure. The ritual prevention is not washing. Another example might be leaving the house and checking the lock only once, without going back and checking again. The person fairly quickly habituates to the anxiety-producing situation and discovers that the anxiety level drops considerably. They can progress to touching something more contaminated or not checking the lock at all, again, without performing the ritual behavior of washing or checking. It has generally been accepted that psychotherapy in combination with psychiatric medication is more effective than either option alone. The medicine. A blister pack of clomipramine, or the brand name anafranil. They give these medicines such hard names to pronounce. I'm sorry I can't pronounce it really well, but I am trying my best, so I apologize for that. The medications most frequently used are the selective serotonin reuptake inhibitors. Clomipramine, a medication belonging to the class of tricyclic antidepressants, appears to work as well as SSRIs, but has a higher rate of side effects. SSRIs are a second-line treatment of adult obsessive-compulsive disorder with mild functional impairment, and as first-line treatment for those with moderate or severe impairment. In children, SSRIs can be considered as a second-line therapy in those to moderate to severe impairment, with close monitoring for psychiatric adverse effects. SSRIs are efficacious in the treatment of OCD. People treated with SSRIs are about twice as likely to respond to treatment as those treated with placebo. Efficacy has been demonstrated both as short-term treatment and in discontinuation trials with durations of 28 to 52 weeks. The procedures. Electroconvulsive therapy has been found to have effectiveness in some severe and refractory cases. Surgery may be used as a last resort in people who do not improve with other treatments. In this procedure, a surgical lesion is made in the area of the brain. In one study, 30% of participants benefited significantly from this procedure. Deep brain stimulation and vagus nerve stimulation are possible surgical options that do not require destruction of brain tissue. In the United States, the Food and Drug Administration approved deep brain stimulation for the treatment of OCD under a humanitarian device exemption, requiring that the procedure be performed only in a hospital with a specialist qualification to do so. In the United States, psychosurgery for OCD is a treatment of last resort and will not be performed until the person has failed several attempts at medication at the full dosage with augmentation and many months of intensive cognitive behavior therapy with exposure and visual response prevention. Likewise, in the UK, psychosurgery cannot be performed unless a course of treatment from a suitable qualified cognitive behavior specialist has been carried out. Children. Therapeutic treatment may be effective in reducing ritual behaviors of OCD for children and adolescents, similar to the treatment of adults with OCD. CBT stands as an effective and validated first line of treatment of OCD in children. Family involvement in the form of behavior observations and reports is a key component to the success of such treatments. Parental interventions also provide positive reinforcement for a child who exhibits appropriate behaviors as alternatives to compulsive responses. In a recent meta-analysis of evidence-based treatment of OCD in children, family-focused individual CBT was labeled as probably efficacious, establishing it as one of the leading psychosocial treatments for youth with OCD. After 1 or 2 years of therapy in which a child learns the nature of his or her obsession and acquires strategies for coping, that child may acquire a larger circle of friends, exhibit less shyness, and become less self-critical. Although the causes of OCD in the younger age groups range from brain abnormalities to psychological preoccupations, life stress such as bullying and traumatic familial deaths may also contribute to childhood cases of OCD, and acknowledging these stresses can play a role in treating the disorder. OCD affects about 2.3% of people at some point in their life. Rates during a given year are about 1.2%, and it occurs worldwide. It is unusual for symptoms to begin after the age of 35, and half of people develop problems before 20. Males and females are affected about equally. Prognosis. Quality of life is reduced across all domains in OCD. While psychological or pharmacological treatment can lead to a reduction of OCD symptoms and an increase in quality of life, symptoms may persist at moderate levels even following adequate treatment courses. and completely symptom-free periods are uncommon. In pediatric OCD, around 40% still have the disorder in adulthood, and around 40% qualify for remission. And that is it for OCD. That is the second and last part. And always remember, materials contained on here are for informational purposes only. The content is not intended to be a substitute for professional advice, diagnosis, or treatment. Always seek the advice of your doctor or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately.
We truly hope that you enjoyed this podcast today. And if it touched your heart in any way, please share it with your family and friends. And please consider donating whatever your heart tells you. If you wish to do so, please go to the following link: anchor.fm/timeoutwithjim. And again, it's ANCHOR.fm/TIMEOUTWITHJIM. This will help us keep this podcast going. Thank you for listening, and until next time, keep your heart flowing, and God bless to all.